1, 2,
And review 70-year-old female
Oh shit, I almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. Where the echo people get? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
Oh. Oh.
Imagine staring at two patients in a single room.
Right.
One of them just survived a massive physical trauma. Her vascular system is completely recalibrating, and her hormones are basically an absolute free fall.
Yeah, total biological crash.
Exactly. And the other patient, they are completely new to the world, covered in fluid, and actively losing body heat by the second.
Which is a terrifying scenario if you aren't prepared for it.
It really is. On a postpartum floor, there's just no such thing as clean math, you know? The straight line from assessment to action kind of vanishes. So welcome to the deep dive.
Glad to be here.
For you listening right now, we know your mission. You are staring down a massive block of obstetric nursing exams, and you really need to know how to think like a safe, effective future nurse.
Absolutely. You don't just want to memorize, you need to understand the why.
Right. So today we are acting as your elite OB exam coaches. We've got this comprehensive clinical guide on postpartum and newborn discharge teaching in front of us, and we are aggressively applying the Pareto principle here.
Yes, the 20/80 rule. We are pulling out the 20% of high-yield concepts, those priority findings, and the safety traps that will unlock, 80% of the value on your exams.
Wait, let's unpack this.
Sifting through all that dense clinical material really means we have to separate the expected from the deadly. We're just skipping the fluff today.
Yeah, nobody has time for fluff on an exam.
Exactly. We're focusing purely on the physiological mechanisms. You have to understand the why behind a symptom because, well, that is how you build actual clinical judgment instead of just, memorizing a textbook.
Right. And clinical priority always dictates that you secure the maternal foundation first, doesn't it?
100%. If the mother is crashing, she obviously cannot care for the newborn. And the foundation of that maternal care actually begins with psychosocial adaptation.
Oh, I know this one. On exams, this usually shows up as Rubin's theory of maternal role attainment, right?
That's the one. It's basically the framework for how a client actually transitions into the identity of a mother. It happens in 3 specific stages: taking in, taking hold, and letting go.
So that first stage, the taking in phase, I always compare it to being in the locker room right after running a grueling marathon. It covers those first 48 hours postpartum.
That is a perfect analogy, yeah.
Right. Because if you just ran 26 miles and tore your muscles, you aren't immediately grabbing a clipboard and planning your training schedule for the next race.
No, you're exhausted. You're just trying to survive the moment.
Exactly. You were thinking, I need water, my legs are on fire, and I just need to verbally process what my body went through. The mother is entirely focused on her own basic needs and the physical reality of the birth.
Which, from a nursing standpoint, completely dictates your interventions.
Right.
If you try to teach a complex infant bathing routine during that taking in phase, that education is going to fail.
Because she's just not there yet mentally.
Right. Her cognitive focus is totally inward. You have to keep your teaching really simple and direct. Then, you have the second stage, taking hold, which occurs over the next several weeks.
So that's when she steps out of the locker room.
Exactly. She shifts her focus to the newborn's needs. She's actively learning parenting skills, and she's really seeking validation. And finally, letting go happens months later.
And that's where she integrates her former identity with her new reality as a parent, right?
Yeah, and it involves kind of grieving the loss of her childless life and accepting the actual infant in front of her rather than the fantasy infant she might have imagined during pregnancy.
So right alongside that psychological shift is this really violent biological crash, which sets up one of the absolute biggest exam traps you will face.
Oh, distinguishing between postpartum blues and postpartum depression. They love to test.
They really do. A classic multiple choice scenario is going to give you a mother crying inconsolably on day 4 and ask for your priority action.
And the key here is the timeline, right? And the underlying mechanism.
Yes, exactly. The baby blues are entirely expected within the first 2 weeks. I mean, the moment the placenta detaches from the uterine wall and is delivered, the body just loses its primary source of pregnancy hormones.
Right. The client experiences this absolute free fall in estradiol and progesterone.
And that abrupt withdrawal is what triggers the weepiness, the irritability, the mood swings. It's a physiological crash. It is not a psychiatric emergency.
Postpartum depression, however, is a massive red flag, and that manifests later, typically over the first 2 to 3 months.
So we're looking past that 2-week mark.
Exactly. And it extends far beyond just weediness. We're talking severe anxiety, a feeling of absolute incompetence, psychomotor agitation, and potentially suicidal ideation.
Which is terrifying. But how do you spot it if they just look tired?
Well, you can't rely on visual assessment alone because the symptoms of normal postpartum exhaustion, like sleep disturbances and appetite changes, they completely mimic depression.
Ah, so that's where the objective screening comes in.
Yes. The priority nursing action is universal screening. You screen every single client using validated tools. You'll see the EPDS, the Edinburgh Postnatal Depression Scale, which is specifically for the postpartum period.
Or the broader PHQ-9, right? The Patient Health Questionnaire.
Right. You are looking for a score that dictates immediate clinical intervention.
Okay, so to recap for the exam. Blues equal first 2 weeks. They're hormonally driven and expected. PPD equals persistent, later onset, and absolutely demands clinical intervention.
Spot on. Now, moving to the physical assessments, exams love to test your ability to separate an expected recovery symptom from an impending disaster.
Let's talk about lochia then, the postpartum vaginal discharge. The expected findings follow a really strict pattern, don't they?
They do. You have rubra, which is dark red for the first few days, then serosa, which is a pinkish brown lasting up to 2 weeks, and finally alba, a yellowish white that can last up to 6 weeks.
And the volume should just be steadily decreasing the whole time.
Exactly. Another completely expected finding is severe uterine cramping, what we call after pains. We actually expect the uterus to forcefully contract back down to its pre-pregnancy size.
Which is driven by that massive release of oxytocin, right?
Yes. Those contractions physically squeeze off the blood vessels at the placental detachment site. That is literally how the body prevents a hemorrhage.
But those contractions have to hurt so much.
Oh, they do. Using NSAIDs like ibuprofen is the gold standard here, because ibuprofen specifically blocks the prostaglandins that cause that severe cramping pain.
Okay, but you really must know when these physical symptoms cross the line into an emergency. Like, the absolute priority, report immediately finding for bleeding, is what?
A client soaking a perineal pad in 1 hour or less.
Right. If you see that, or if you palpate a boggy, soft uterus instead of a firm one, you are looking at a postpartum hemorrhage.
Yes, the uterus has lost its tone, those vessels are bleeding freely, and you must intervene instantly. You're doing fundal massage and pushing uterotonic medications.
Got it. Now, beyond hemorrhage, we have to evaluate the cardiovascular system. A new parent is obviously going to be exhausted and probably dealing with tension headaches from sheer lack of sleep.
Which is expected. But distinguishing that normal headache from a red flag requires looking at the whole systemic picture.
So if a client complains of, say, extreme swelling of the hands and face, a relentless headache that does not improve with acetaminophen, or visual changes like seeing spots or floaters.
That is definitely not sleep deprivation. Those are the hallmark signs of postpartum preeclampsia.
And what's fascinating here is the pathophysiology, right? I mean, preeclampsia doesn't just magically vanish the second the baby is born.
No, it doesn't. What's fascinating here is that the systemic endothelial damage is still very much present. That relentless headache and those visual spots are caused by severe cerebral vasospasms.
Wait, so the blood pressure is so high, it is literally spasming the blood vessels in the brain and the retinas.
Exactly. It severely irritates the central nervous system, which is why you might also see hyperreflexia, overactive reflexes.
So a headache with visual changes is a total stop everything, assess blood pressure, and prepare the magnesium sulfate moment.
Absolutely.
Uh-huh.
Because that client is at imminent risk for a full-blown seizure.
Okay, so the maternal vascular system is stabilized, her bleeding is controlled, and we've ruled out preeclampsia. But right next to her, there is an entirely separate physiological crisis unfolding.
The newborn.
Yes, the newborn has just gone from a perfectly temperature-controlled 98-degree fluid environment into a freezing, dry room.
Which brings us to a massively tested safety priority, thermoregulation.
Right. The World Health Organization strictly recommends delaying the baby's first bath for a full 24 hours, which honestly sounds incredibly counterintuitive to most new parents.
I know, because the baby is covered in vernix and blood and amniotic fluid, and we were just like wiping them down and leaving them like that for a whole day.
But it is a completely non-negotiable safety measure, isn't it?
It really is. Newborns have this massive surface area to volume ratio, meaning they have a huge amount of skin relative to their internal body mass, and they are born soaking wet.
So they just lose heat to the environment incredibly fast.
Exactly. And crucially, full-term newborns lack the neurological maturity and muscle mass to actually shiver. An adult shivers to generate kinetic heat. A newborn just cannot do that.
Right. So to survive that cold environment, they rely entirely on a finite supply of something called brown fat.
Yes, brown fat. It's a highly vascularized adipose tissue located around their neck, their shoulder blades, and their kidneys.
I always picture brown fat as like the emergency backup generator in a hospital.
Oh, I like that.
Yeah, when the power goes out, or in this case, the baby gets cold, the central nervous system flips the switch, the generator kicks on, burning fuel to keep the lights on and the baby warm.
Right.
But just like a backup generator, it burns through its diesel way too fast. If you run it too long, you drain all your resources, and the hospital goes completely dark.
And in the newborn's case, we have to look at what that biological diesel actually is. The cascade that follows is exactly what exam writers want you to recognize.
So what happens when that generator kicks on?
Well, when cold stress triggers the sympathetic nervous system, it releases norepinephrine to metabolize that brown fat. But this massive increase in metabolic rate requires two vital things: glucose and oxygen.
Uh-oh, so the baby rapidly burns through their blood sugar stores.
Exactly, leading directly to profound hypoglycemia. And simultaneously, this metabolic overdrive consumes massive amounts of oxygen, leading to hypoxia.
Wow. And as the baby struggles to breathe, lactic acid builds up, dropping their blood pH and causing metabolic acidosis.
Yep, so cold stress isn't just, oh, the baby's a little chilly. Cold stress directly causes low blood sugar, respiratory distress, and severe acid-base imbalances.
That is terrifying. Okay, so knowing how dangerous heat loss is, you need to spot the 4 mechanisms of heat loss in a multiple choice scenario.
They will definitely test you on these.
First up is evaporation. This is heat literally turning into vapor when the newborn is wet. Think of the amniotic fluid right after birth, or giving a sponge bath.
And your priority nursing action there is to dry the infant immediately and thoroughly.
Right. Second is conduction.
Yes, conduction.
Yeah.
This is heat transferring through direct contact with a solid cold surface. The classic exam trap here is a nurse placing a naked baby directly onto a cold metal scale to weigh them.
Without putting a protective paper or a warm blanket down first, right?
Exactly. The heat conducts straight out of the baby's skin right into the metal.
Okay, third is convection. This is heat being carried away by cool air flowing over the baby.
You'll usually see a scenario where a bassinet is placed right under an air conditioning vent, or, a newborn is carried down a drafty hospital hallway without a hat on.
And fourth is radiation. This one honestly traps so many students because it involves absolutely no direct contact.
Right, radiation is heat transferring to a nearby cold surface just through the air.
A really common scenario is placing the baby's crib right next to a cold, uninsulated external window in the middle of winter. The baby isn't touching the window at all.
But the cold glass literally pulls the radiant heat off the infant's body anyway.
So it's evaporation, conduction, convection, radiation. You have to understand the physical environment, not just memorize the definitions.
Absolutely.
Yeah.
Now, once we stop the newborn from burning through their metabolic reserves just to stay warm, the priority shifts to protecting them from infection and injury before they are discharged.
Which brings us to umbilical cord care, a really fundamental, high-yield topic.
The physiological goal here is to let Wharton's jelly, that's the tissue inside the cord, dry out completely. This causes the vessels to necrose and the stump to eventually fall off.
So the golden rule is to keep the stump clean and dry, just exposing it to the air.
Exactly. We only give sponge baths. We never, ever submerge the baby in a tub until that cord separates, which usually takes about 1 to 3 weeks.
And you must teach parents to fold the front of the diaper down, like, below the cord, right?
Yes, to prevent urine and feces from soaking into it and causing an infection.
So expected findings include the stump shrinking, turning dark brown or black, getting hard like a piece of plastic, and maybe a few drops of blood when it finally detaches. That is all normal.
Completely normal. The priority report findings, however, indicate omphalitis, which is a severe infection of the umbilical scump that can quickly turn into systemic sepsis.
So what are we looking for there?
You are looking for foul-smelling yellow or green discharge, spreading redness or edema at the base of the skin, or an infant who just screams in absolute pain when the surrounding skin is touched.
Got it. And a massive safety point to teach parents. Never, ever pull the cord off, even if it's just hanging by a tiny, tiny thread.
Oh, please no. You will cause an active hemorrhage. Just let it fall off naturally.
Okay, let's talk about circumcision care, because that is another area entirely riddled with exam traps.
It really is. You'll generally see 3 methods used: the Mogan clamp, the Gumco clamp, or the plastic bell.
So for the clamp procedures, the prepuce is excised, leaving a raw, open wound on the glands.
And the priority nursing action for that is applying a generous amount of petroleum jelly and sterile gauze to the tip of the penis with every single diaper change.
Because that prevents the raw tissue from adhering to the diaper and tearing open when the diaper is removed, right?
Exactly. However, if the provider uses the plastic bell method, a plastic ring is left over the glands to cut off circulation to the foreskin.
And that changes the rules completely.
It does. You do not use petroleum jelly with a plastic bell. The lubricant can actually cause the bell to slide off prematurely, which risks severe penile injury.
Okay, so let's talk about the absolute biggest exam trap for circumcisions.
Oh, I know exactly which one you mean.
Yeah, it's day 3 postpartum. The parents call the clinic in an absolute panic because there is this thick, yellowish exudate covering the tip of the penis, and they're asking what kind of soap they should use to wash the infection off.
You instruct them to stop immediately and touch absolutely nothing.
Right, because that yellowish film is not pus, is it?
No, it is granulation tissue. It is the body's natural, totally expected physiological response to healing a mucosal surface.
So if a parent or even a nurse scrubs that exudate off,
They will strip away the newly formed cells, cause intense pain, trigger bleeding, and completely reset the healing process. You do not scrub the yellow exudate.
okay, so what are the actual priority reasons to contact the provider then?
They are twofold. First, if the baby does not urinate within 12 hours post-procedure.
Because the trauma of the procedure can cause severe edema, right?
Yes, it swells the tissue so much that it physically occludes the urethra, causing severe urinary retention.
And the second reason?
Second is if the bleeding exceeds the size of a 2-inch circle on the diaper. A few drops of blood are expected. A soaked 2-inch ring is an active hemorrhage.
Perfect. Shifting to environmental safety, SE-wide sudden unexpected infant death prevention is highly tested.
It's critical. The anatomical mechanics of a newborn's airway demand a firm, completely flat sleep surface.
The teaching is pretty universal now, isn't it? Back to sleep, room sharing for at least 6 months, and absolutely no soft objects, pillows, bumpers, or loose bedding in the crib.
None. And car seat safety follows a very similar, strict mechanical logic. The infant must be in a rear-facing seat.
And the chest clip must be positioned exactly at armpit level, right? Resting over the sternum, not down by the soft tissue of the stomach, where it could cause internal organ damage in a crash.
Yeah, and importantly, no bulky winter coats or thick blankets underneath the harness straps.
Because in a high-impact collision, that fluffy material just compresses instantly to nothing, making the straps dangerously loose and actually allowing the infant to be ejected.
Wait, hold on.
Yeah.
We're telling parents, no loose blankets, keep the crib completely empty to prevent suffocation. But then we take a blanket and tightly wrap the baby into a burrito to swaddle them.
It is quite the paradox.
It really feels like a massive contradiction to a new parent. I mean, how is swaddling safe if blankets are dangerous?
Well, we swaddle them to mimic the confined space of the womb. It really soothes the infant and dampens the Moro reflex, the involuntary startle response where their arms throw outward and they just wake themselves up.
Right, but swaddling is highly conditional, isn't it?
Yes, the safety of the swaddle disappears the absolute moment the baby shows any signs of attempting to roll over, which developmentally hits around 3 to 4 months.
Because if a baby rolls onto their prone stomach while their arms are pinned inside a swaddle, they completely lack the leverage to push their face off the mattress.
Exactly. It goes from a soothing mechanism to a massive suffocation risk instantly.
And the mechanics of the lower body during a swaddle are just as critical. The blanket must be snug across the chest to secure the arms, but it has to be completely loose around the hips.
Why is that again?
Because the newborn's acetabulum, the hip socket, is mostly cartilage and highly malleable. If you wrap a newborn's legs tightly and force them straight down into extension, you are basically levering the femur right out of the socket.
Ouch. And over time, that causes developmental hip dysplasia.
Exactly. So the rule is snug on top, loose on the bottom, and stop the moment they attempt to roll.
So we've got a baby who is warm, safe from infection, and sleeping on their back. The last piece of the discharge puzzle is fueling them for growth.
Right, nutrition.
If a client is expressing human milk, exams will aggressively test your knowledge of storage guidelines because improper storage turns that milk into a terrifying bacterial breeding ground.
And the key to this is understanding what human milk actually is. Freshly pumped milk is a living fluid.
Really? Like active cells?
Yes, it is packed with active leukocytes, macrophages, and immunoglobulins that actively hunt and destroy bacteria.
Oh, wow.
Because of these living cells, fresh milk can safely sit at room temperature for up to 4 hours.
But after that 4-hour mark, those living cells start to die off, right?
Right, and the milk loses its active defense system. You must get it into the refrigerator, where the cold temperature suppresses the bacterial replication. It's safe in the fridge for up to 4 days.
And if you need to store it longer than that, it goes into the freezer, where it's safe for 6 to 12 months.
Exactly. Freezing destroys some of the living cellular components, but it perfectly preserves the macronutrients, the fats, proteins, and carbohydrates.
So the rule is 4 hours room, 4 days fridge, 6 months freezer.
Perfect. And when you thaw that frozen milk, it must be used within 24 hours in the fridge.
And you can never, ever refreeze human milk once it has been thawed.
Never. The initial freezing process expands the water content and damages the cellular walls in the milk. If you thaw it and refreeze it, you're essentially creating a compromised, cell-free fluid that will just rapidly host dangerous bacterial growth.
So what does this all mean? If you're walking into that exam tomorrow, you have to mentally separate the expected adaptations from the deadly complications.
Yes, you look at the mother, baby blues in the first 2 weeks. Expected, driven by plummeting hormones.
But if she's soaking a perineal pad in under an hour?
Deadly. You are looking at a postpartum hemorrhage. You need fundal massage and medications immediately.
And if she complains of a relentless headache and visual floaters, you do not write it off as fatigue.
No, the endothelial damage of preeclampsia is causing cerebral vasospasms. You must check the blood pressure to prevent a seizure.
Then you look at the newborn. The environment is a threat. You delay the bath for 24 hours because cold stress triggers the sympathetic nervous system to burn brown fat.
And burning that brown fat isn't just shivering. It directly drains their glucose and oxygen.
Leading straight to severe hypoglycemia and hypoxia.
Exactly. You must dry them to prevent evaporation, keep them off cold scales to prevent conduction, away from drafts to stop convection, and away from cold windows to halt radiation.
You look at the procedures next. Fold the diaper below the umbilical cord. For circumcisions, when you see that thick yellow exudate on day 3, what do?
You do absolutely nothing. It is expected granulation tissue. Scrubbing it off just restarts the injury.
But if that baby hasn't voided in 12 hours, you report it because edema is occluding the urethra. Finally, the sleep environment. The crib is flat and empty. The car seat chest clip is at the armpits, not the stomach. And the moment that infant tries to roll over, that swaddle goes away forever.
You just tackled a massive block of high-yield obstetric nursing knowledge.
It really did. By understanding the underlying pathophysiology, the actual why and how behind the symptoms, you aren't just memorizing random facts to pass a test.
Right. You are building the clinical judgment required to walk onto a postpartum floor and be a genuinely safe, effective nurse.
Absolutely.
And, if we step back and look at the bigger picture of maternity care, I want to leave you with a final thought to kind of analyze on your own.
Let's hear it.
In our modern medical system, intensive maternal monitoring stops abruptly the moment the client is discharged. They are sent home to navigate a massive physiological recovery, hemorrhage risks, and shifting mental health, all while being entirely responsible for a vulnerable newborn.
It's a huge burden.
It is. So how might maternal mortality and postpartum depression outcomes change if we monitored the entire 4th trimester with the same intensive remote data tracking we applied to the 3rd trimester?
Oh, that's an interesting thought.
What if a mother's blood pressure, lochia volume, and psychosocial data were monitored continuously at home, intervening before a symptom becomes a crisis?
It really highlights a massive gap in current standards, and it shows exactly where nursing innovation is desperately needed.
It really does.
Well, keep questioning those standards of care. Keep looking for the physiological mechanisms behind the exam traps. Good luck on your exams, and we'll catch you on the next deep dive.